Hi, welcome to Let's Talk About Mental Health. I'm Nels and I'm an addiction psychiatrist, and I work in Southern Vermont.
And I'm Robert Stack, and I'm a licensed alcohol and drug counselor, licensed mental health counselor. Good evening.
And as a reminder for sending us your comments and questions, we have a Facebook site and an email address that we'll put on the screen through the show. The email is questions@letstalkvt.com, and the Facebook is facebook.com/letstalkvt. Okay. And tonight we have a guest on the program, Dr. Mary Olson, who's a professor at the University of Massachusetts Medical School,
yes,
as well as on faculty at Smith College,
yep,
and is one of the founders of the Institute for Dialogic Practice.
Yes.
And so we've mentioned open dialogue at times on the show around our interviews with Robert Whitaker, but it'd be nice to hear from the perspective of someone who's intimately involved with it.
Yeah. Okay. So, do you think it'd be useful for me to talk about how I first came across open dialogue?
Yes.
Okay. All right. So I'm a family therapist, and I, for many years, was a family therapist in the Pioneer Valley in Western Massachusetts, and then in the mid-90s. What I began to notice is that family therapy training programs began to shut down. Family therapy teams began to become disbanded. And overall, family therapy seemed to be disappearing from the clinical landscape in Western Mass, where I was working and teaching as a family therapist. And I began to wonder, were these just bad ideas? What's going on? So at that time, I was invited to become part of a research study that was started by the dean of the Smith College School for Social Work, Anita Lightburn, and she wanted to examine the effects of managed care on the treatment of children and families. And so I joined this research project, and we began to look at what was happening in the Northeast and why family therapy began to vanish from the clinical landscape. During this research study, what we discovered is that the new insurance practices were reinforcing a biomedical model of psychiatry, that the way that the biomedical model that emphasizes medication as the only real thing you could do, the way that that became routinized in ordinary clinics and agencies was hand in glove with the advent of managed care and a much more restrictive economic context for mental health. As part of that, we saw that there were changes not only in family therapy, but that all relational therapies, all psychotherapies were being downplayed, and that psychopharmacology was being emphasized in ordinary clinics and agencies. So, we studied the trends associated with that there was an erosion of, clinical thinking, that procedures and policies were being trumpeted, and, theories of human suffering were being sidelined. So mental health care was becoming much more bureaucratic. So as part of this research study, I stumbled across an early article on open dialogue. And what astonished me was that in this remote corner of Western Lapland, there was a family-centered, network-centered psychiatric system that was available to everyone, and that saw the family therapy tradition as a serious agent in the treatment of the most severe psychiatric crises and conditions.
Wow.
And that was a vast difference from what was happening in the United States, where ideas about understanding an individual in a context, that important idea, which was central to family therapy, was not an idea that that any longer was being taken seriously by mainstream psychiatry. And instead there was this shift to the notion that psychiatric problems and conditions were solely the result of chemical imbalances in the brain, the broken brain. So then after that, I had the great good fortune to be able to go to Finland and to study open dialogue, and I was very impressed. And I developed a partnership with one of the main developers, Jaakko Sekula, and came back here in 2003, and then looked around and found like-minded practitioners and researchers at UMass Medical School. So it's taken us 12, 13 years to have any kind of tangible progress. But now we do have a research study at UMass Medical School. I also started this training institute with Jaakko Sekula, and we've trained teams, probably most notably advocates in Framingham, Massachusetts, has been training with us. And we've also trained people in Vermont. And so there's a kind of critical mass now in Massachusetts of practitioners, researchers, who are all interested in open dialogue as a more psychosocial approach that integrates, relational therapy as well as medication.
Do you get much, so it's nice there's a critical mass. I think we've criticized quite often this idea that there's such a thing as a chemical imbalance, and where psychiatrists became these technicians of sort of twisting the dials for serotonin, dopamine, norepinephrine, and how, the relationship being lost, and how it really then you lose the richness of the individual as well as the entire network. So
that's right.
It sounds like, in the idea of minimizing costs and complexity, just prescribing medication, that's the way. And we're finding out that that's not really cost effective either.
Well, open dialogue has the best outcomes for first episode psychosis in the Western developed world. So one of the things that the Finnish team did at Karaputis Hospital, where open dialogue was developed, is they began to track their outcomes from the very beginning. And what they found, in several studies at 2 years, at 5 years, that 80% of their patients suffering from so-called psychosis are working, studying, or looking for a job at the 5-year marker. And in the US, we're not obtaining outcomes anywhere close to those outcomes.
Yeah. One of the things that struck me when I was reading your handout and what you just said, my original training was in the addiction field, alcoholism, back in the 28-day treatment thing. But one of the things that we did believe in, that it was a family illness, and we would talk about it, and we would have, and I told you earlier, I had a family day, and I would talk about the effect of a chronic illness on the family. And then we even started looking at children of alcoholics, and that was a whole nother movement. But it sounds like one of the things, we were always like the stepchild of psychiatry, if you will, if we even got that far. We were substance abuse in a separate building kind of thing.
Stepchild, right?
But we knew this, that we were sending them back to be with their family, and this was what they lived with.
Right.
And also, I know we talked about this last week, and I won't go into it, but the whole issue about families have hope, and there's relapse, and there's symptom return, and a lot of fear involved sometimes with chronic illness, because often there's no real cure per se. And I really like this. I want you to say a little bit more when there was that meeting and putting them all on equal level, because I didn't do that. What I did was sort of show a film, have a discussion. Here's what we know, here's where you need to go. And so I was sort of struck by that you have another approach about how to treat family.
Well, I think open dialogue believes that a crisis, even though it may be centered in an individual, is a crisis in a network. And that it's very important to involve not only the person at the center of concern, but everybody who's close to that person, who loves that person, and who's involved in the care of that person. We don't blame families. We don't look for what's wrong with families. We try to engage both the person who is at the center and everyone close to them as partners in a recovery process that begins the minute they walk in the door. I think that as open dialogue practitioners, given the success that we've had with this approach, we do bring a lot of hope. And we do see that people can, sometimes they recover completely, sometimes people learn to manage their symptoms, but they can go on and live meaningful lives with work and love. As Freud said, those are the coordinates of health. And I think that there is no reason for families to abandon hope. I really believe that, particularly with this approach, that I have been getting really remarkable outcomes. And that's really the foundation of my belief in this way of working. And the starting point is to make a connection, not try to fix it, not even try to understand it, but try to make a connection with the person who's at the center and with the people who are taking care of them. And try to give everybody an equal voice. So the voice of the person at the center of concern and the voice of the psychiatrist are equal.
Yeah, but do you mind? No, one of the things that strikes me, though, I remember in graduate school, and I was, we used to have problem lists, a treatment plan, right? And then I took a course in solution-focused therapy.
Yeah.
I'm like, okay, so this is what we'll do, right? But listening to you and reading your stuff, it's like, when you make that presumption that you had the solution, then you need to give it down to someone. I mean, you really make that clear. And there's a part of me that just sort of like, that's not what I've been trained.
Right. None of us have been trained that way.
And that's what I'm saying too. One of the things we were taught was that the therapeutic alliance or the relationship you feel with the counselor or the physician, who it might be, is critical.
Right.
And you need to feel that early on, or else
Right.
you should probably just go and find somebody else and try to find that alliance with them. So I understand that, but then when you look at the position we tend to feel ourselves put into, it's like, the experts with a solution, and then, as you were saying, sort of a monologue at the end where I'm going to tell you what I think is going on and what we should do. So this must be a transforming experience for everybody, the psychiatrist, the therapist, that sort of come down and consider themselves equal, families and the clients as well, if you're not used to being elevated to the point of being considered equal either.
Well, I mean, that's the starting point. You start with what we call, dialogical equality. Everybody has a voice. As experts, we drop the clinical gaze, which is very important. And you go in with a kind of stance of being with rather than doing to. As you begin to work with the family, though, as you begin to listen, as you begin to make sense of what's going on, all your expertise is important and it comes into play and you use it, but you use it as a response to what you're hearing, what you're noticing, what you're seeing, rather than coming in a top-down way and making assumptions. So we start by noticing. I mean, I'm working with a family now. We've been working with this family for 4.5 years. The young man is doing very well. He has had every label, psychotic, schizophrenic, whatever, trapped in this for 16 years, and now he's really coming out of it and doing quite well. But when we started, we didn't start with the idea of what is schizophrenia. We started with the idea of what is that limp that he has? Why is he limping? That tells you much more about this human being than your concept of schizophrenia. So start by noticing things, trying to understand who is this person. And then as you do that, the people you work with can sense that you are regarding them as human beings, that you're trying to make a connection, and then they will tell you what is really going on. And then as you begin to understand the situation, that's when your expertise is really critical. But as I said, you're responding to that person and family. You're not coming in with your concepts and assumptions and basing a kind of top-down approach on this conceptual framework, which may or may not apply to this family.
And
does that make sense?
Yeah, and what's interesting, if you're in the field of counseling therapy, some class you take is going to talk about the therapeutic relationship,
right.
And making a connection, and it's still professional,
right?
You know what I mean? It's like paragraph 3, we're going to have this therapeutic relationship, and what you're saying is that even that is almost a false approach, if you will. You know what I mean? Like, I'm the therapist. I'm going to establish a therapeutic relationship with you, and this, what we're going to do is
we're going to make it happen.
Yeah, this is important to my training. The other thing that sort of struck me was this idea, and I hope this is not a spoiler alert when I talk about what's in your paper.
No, not at all. Go ahead. I don't care.
No, I said it earlier. It used to be, you would sit there And almost a variation would be, so what brings you here today?
Right.
You know what I mean? It was like, tell me the symptom, tell me the crisis. And then here it says, the question you want to ask is, tell me about the discussion that led up to the decision to come in here today.
That's right.
Which is so much more. I mean, as soon as I read it, I laughed. I was like, oh, God, this is exactly right.
Right.
And because, tell me about the dynamics.
Yeah,
Right.
How did we get here?
But tell me about how, the person we're all focused on, what was his reaction?
Right.
Oh, God, do we do this again? I'm going to be the object,
Right.
And then you're going to have one parent that says, oh, just take your meds. Or
Right.
the other parent say, well, it was this. Anyway, could you talk to that, like that approach?
Sure. So we start with the idea of, the history of the idea to have the meeting. And that actually comes from the work of Tom Anderson, who was a Norwegian community psychiatrist. And the idea is that when you're working with a whole network, everybody's going to have a different idea about this meeting. There are going to be people who want to be there. There are going to be people who don't want to be there. You want to begin with that presenting edge and open up a space for everyone already to have a voice and around this very first issue, which is the idea to have this meeting, the idea of therapy. There are going to be people who, in the family, who feel therapy is not the right approach. We should go to our primary care physician. We should do this. We should do that. You want to know whether the person that everyone's concerned about wants to be there, and how are they viewing the situation. So it's a very important question, but it's also a question that doesn't take a position immediately about whether or not there's a problem. Mm-hmm. So, if I turn to the person who everyone's concerned about and said, what brings you here? That's assuming that person is the problem, that they agree there's a problem. It puts them in a very difficult position from the very beginning because they're being defined without having a voice in how they're being defined.
And I thought that was a great thing when I was reading that about the voice and about being equal.
Right. Yeah.
I've never experienced it, I must say.
Right.
And I have all these things in my head, like, well, that won't. Well, how does that work? But
well, one of the things that equalizes the professionals and the family is the reflecting process, mm-hmm. because, let's say the two of you do a reflection. Then I get to comment on your reflections. So I get a voice in deciding which of those reflections is relevant, which of those reflections, do I feel are off base. So it's built into this way of working. The person and the family have a way of commenting on what the professionals are saying. And that's an equalizer.
Yeah. Mm-hmm. Something you said earlier made me think about sort of the Eastern position about the beginner's mind is open to everything and
Yes.
the expert's mind is open to nothing.
Right.
That in a way, when you talked about this approach to it, it's almost like you've got to make room in your expert mind to sort of see it as a beginner again, to engage in this process.
Absolutely, and that was probably the watershed for me in terms of my own clinical work. When I didn't think I had that clinical gaze, looking for what's wrong with this person or family, but I did have that. And when I dropped that and just started to go in and talk to people and hear what they have to say, my work really changed and improved quite dramatically. One of the things is that the family, the person at the center can feel the difference. If you're going in and immediately evaluating, or you're immediately diagnosing or objectifying the person or the family, there's a subtle way in which that's communicated, and people begin to protect themselves against that. But if you really can go in with a beginner's mind, it's a much more trustworthy context, and the person and the families will respond to that.
And I think I've always thought that I'm starting to get to the point where I feel that medications are less important, even maybe harmful in some cases. And as I sort of mature away from seeing basically how the DSM-4 diagnoses are not all that valid, and I've gotten away, and then the idea that sitting in an office is I'm in a box with somebody and I'm missing the entire context around this, to realize that I'm I'm not a psychiatrist treating depression. I'm not an addiction doctor treating opioid dependency. But I'm more or less, I happen to be a physician who's trying to work on quality of life issues. And that's brought me a lot more satisfaction. And I'm hoping that maturity shows itself as well in the work that we do with people. So I'm talking about beginner's mind and expert mind, and there's something about having come to the point of being an expert to then sort of empty and bring yourself to that as well.
And your expertise remains important. I mean, I don't think it's an either or, but I think we begin with this kind of openness of mind that people sense. And then as it unfolds, you can use your knowledge in helpful ways. So I wouldn't throw out the expertise. I wouldn't throw out your knowledge of opiate addiction or whatever. But I think it's used differently, and it's used with a much lighter touch.
There's a phrase in there that they use, a tolerance of uncertainty.
Yes.
Which when I read it, I thought, oh my goodness, because I think sometimes I had the answers, and this sounds terrible. It really does, Almost doesn't matter who was sitting on the other side. I still had, but there was a certain comfort in that. You know what I mean? And I trusted my training. I trusted my experience. I trusted the work that I had done. And so this idea of like being so open-ended and so trusting that you're going to approach it with like, well, we don't know what's going to happen here. We're not sure what this is going to be like. I don't know. It just strikes me as so different. I mean, it's just
it is.
How do you let go at the same time? Because there's a part of me that's crying out like, who's in control here? Who's in charge? You know what I mean? Like, I'm sorry.
Right.
But I don't get that. I mean,
no. I mean, I think it's. I think what you're saying is very, very understandable. I think that having the experience of being in the meetings clarifies some of that. It's very hard to kind of convey how these meetings are helpful in the abstract. So, I would love for you to be able to participate in a treatment meeting, and you would get a sense of how the tolerating uncertainty is really in the service of a better understanding.
Well, Tim, if we look at the history of psychiatry, we talk about the diagnosis does not say the same, the idea of what treatments are good does not say the same. We've done some awful things in the service of being, brain technicians. And I think when you look at that history and realize, what we're doing now is probably going to be really frowned upon in 20, 50, or 100 years. So loosen up, right? Maybe don't be so certain about what we're doing, because we're fooling ourselves if we think we got it now.
Now, earlier when we were talking to you before the show, you said there was two basic things that you thought were the basic one word or two answers.
For open dialogue?
Yeah.
Well, I think the basic thing is this idea that it's organized around reducing isolation.
Yeah.
And there's enormous literature backing this up, that reducing isolation and giving people hope in and of themselves are very, very valuable and really mediate the trajectory of these very severe crises and conditions. Because when we isolate people and medicate them, and we give them labels that take away their hope, we're not just describing something or treating something, we're also shaping a future. And that's why it's so important to try to work with people in a way that supports their relationships and gives them opportunities for expression and for creativity, and that we don't over-medicate and we don't emphasize that narrative at the expense of, their personhood or their experience or what they've been through or the need for them to talk about their suffering.
There's been a movement to reduce stigma of mental illness, and yet I can't help feeling that the structure of the way we deliver care reinforces stigma.
Right.
There's just no way around it. I mean, it's nice that everybody is saying we want to eliminate stigma, but when you have an identified mental health patient, you have an identified, you know what I mean?
Right.
And here's your label, and here's your meds, and, there's something wrong with you. if you want to call it by another name, I think they still get that sense of stigma, that there's something wrong, really wrong with them.
Right, and that's really, we have to get away from that kind of deficit-based thinking. Any person faced with stressful enough circumstances can develop what we call a mental illness. There isn't an us versus them. It's really a response to very, very difficult circumstances. And any one of us could develop those symptoms if we were exposed to those circumstances.
I used to think that family therapists like you were probably some of the best therapists out there. Because a lot of us, like I did addiction, I just talked to alcoholics or addicts, but family is so complex.
Right.
Do you ever do work with family without the person present? I mean, has that been helpful for them?
I try to work with everybody together,
Sure, yeah.
but sometimes we do, break into subgroups depending on what the situation is and who can talk with whom. Sometimes parents will come to me and they're extremely worried about a child, and the child is just refusing to come into therapy. And I will meet with the parents to try to give them the support and talk with them and explore their ideas and give them hope. I just, I'm just completing some work with a family where we started that way, and then eventually the son came in, and it's had a very, very positive outcome. He's decided to go into a very good program to address, the issues that he's been trying to deal with.
And you mentioned this earlier, and I don't mean to interrupt. I'm sorry.
No, go ahead.
But you mentioned that I used to believe within every person they had the solution, they had the answer. And you said something before the show. You said, and people want to get better.
Yeah, they do.
And it's almost like sometimes, if you've worked with clients, sometimes you would get away as if they were being resistant to getting better. You know what I mean? And you would get angry at them for not getting better. And,
right.
and I don't know if that ever happened to you, but that's how it would come across. And when you say that, does this reinforce that idea?
Absolutely. I think that, I think ultimately open dialogue creates a context where the self-healing capabilities of the person and family are activated. And once that happens, it's astonishing because the family will start to really change and grow and transform in ways that the professionals could never anticipate.
Right.
Now, when we talk, and there's these trends, right, where you get isolated, stigmatized, boxed into a certain identity, and the open dialogue it seems to sort of build off of what's basically our evolutionary sort of species need for connection relationships. And this is maybe for a whole other show, but I'm wondering how the elements of open dialogue could sort of infuse family life, or could infuse our current mental health system to be more natural.
Yeah, absolutely. I think that that's a very good point. It's something quite large to try to contemplate. How that would be, but as we were talking before the show started, open dialogue isn't just an approach. It has a philosophy and an ethics behind it around, respecting each person, giving each person a voice, no matter how hard that person is to understand. Part of the skill of open dialogue is knowing how to work with people so that they become less and less, difficult to understand and more lucid. That everyone's voice is equal, that we try to have a kind of democratic atmosphere, a humanistic atmosphere, and that as a profession, that professionals are more transparent.
Now, thank you so much. The half hour has gone by so quickly. It's been great having you.
Thanks.
And we have a way of contacting you. I hope it's been up on the screen if people have questions or anything like that.
Absolutely, yeah.
Any closing comment?
No, it's been an absolute pleasure.
Thank you very much. It's been a pleasure to talk to
really
the two
nice
of you.
having you. And
Thank you.
I hope more people pay attention to it.
Okay, thank you.